So good morning and thank you to the organizers for inviting us for this session on management of locally advanced cancer of the esophagus. And this is going to be a panel discussion. So may I invite Dr. Suraj Pawar, Sharad Desai, Sumit Basu, Anil Tibnewal, Mehboob Basade and Dr. Amit Bhatt. So we have two surgeons, two radiation oncologists, and two medical oncologists. While they come, we'll just start off with, as per the organizer's request, this is going to be the question which we are going to ask the audience for audience poll, and then the same question will be repeated at the end of the session. Okay, so we'll see what happens at the end of the panel discussion now. Do we have all the panelists? 1, 2, 3, 4. Ready? We're missing someone. This is the second question for poll. Pre-panel discussion poll, and then we'll have the same question at the end. Okay, so once again, we'll see later what happens to this. Okay, so to start with a few introductory comment about cancer of the esophagus. It is a disease in transition, from in terms of the etiology and anatomic distribution, which has changed over the last 2 decades. Conventionally, this was a blue-collar disease with predominantly squamous cancer affecting middle and upper is part of the esophagus. But over these last 2 decades, we see that it has changed from esophageal squamous cancer to glandular cancer, which is affecting lower third esophagus and cardia. And so also there is transition of treatment from only local, emphasis only on local treatment in terms of either surgery or radiation therapy to now management with a multimodality team. So before we go into the actual discussion, let us first get one thing cleared. How do you define a loco-regionally advanced esophageal cancer? And I would request Suraj, maybe, because most of the patient would come to surgeons first. Suraj?
So obviously anything more than T2, T1A, T1B would be early, but anything T2, T3, T4 would be defined as locally advanced esophageal cancer.
So everybody agrees. So T2 to T4A, which is resectable T4, N plus would be loco-regionally advanced cancer.
Yes.
Would T2, early T2, would you like to define, split T2 into early T2 and a little late T2? Because it's a big range, A T2 with N0 early stage. Would you like to put it in the operable, straightaway operable cancer?
Yeah, so that's a very good question. T2 early, T2, 1A, whatever.
Yeah.
Can straight away go for surgery.
Because that is how we will define the subsequent treatment.
So locally advanced operable, straight away operable is T2 would be straight away operable. We may or may not think about NACTRT, the next question, but yeah, T2 early stage.
Yeah, Sharad also agrees.
Yeah, basically locally advanced is resectable, but then like if that in T2, if the tumor is very small, less than 3 centimeters,
right,
and especially if the biopsy is very something like well differentiated.
So maybe early T2 N0 would still be upfront surgery kind of a situation.
Upfront surgery.
So we'll start off with clinical case. A 71-year-old gentleman presented with dysphagia of 2 months duration. He underwent endoscopy and he was found to have circumferential ulcerated tumor in the distal esophagus reaching up to the G junction, starting from 38 centimeter onwards. The stomach and duodenum was normal, and biopsy was squamous carcinoma. So, sorry. This is the endoscopic picture, obviously locally advanced tumor. And this is the PET CT scan. I'm not going to ask on what investigations to be done and all that because, I think it's important to discuss more about management rather than how do you reach to the diagnosis and all that. So this is the PET scan which is showing again a circumferential lesion involving lower third of the esophagus. The tumor had SUV of 17 plus and there were sub-centimeter, very low avidity nodes in the gastrohepatic region and subcarinal region. So how do you proceed for something like this? And again, I would start with maybe Sharad, surgeon.
How do we go about it?
How do we go about it? Yeah.
See, so this is a resectable case again. So I would prefer to go in for concomitant chemoradiation therapy and then follow it up with surgery.
So the cross protocol.
Pardon?
The cross protocol, you would like
to
give
cross protocol,
chemoradiation therapy
45
concomitant.
degrees.
Because cross protocol has changed everything for locoregionally advanced cancer, both squamous as well as adeno-CA. And your choice would be to start off with CTRT.
Yes, CTRT.
But do you think today we have role for induction chemotherapy followed by reassessment and possible surgery?
Sir, we are a little personally biased to chemoradiation therapy. Because we feel it's radiation therapy, if it has to be given, it can be given only better, preoperatively.
No, I'm leaving apart the bias. Is there any role for induction chemotherapy alone?
Yes, there are. We used to practice chemotherapy when we didn't have a radiation machine in the initial stages. So, and that is how many people practice also. People claim to have equal results or equivalent results. But still, my preference would be for chemoradiation.
Yeah, Suraj, what would you like to do?
So, there's no evidence neoadjuvant chemotherapy versus NACTRT. There's no evidence one is better than the other. But yeah, once the cross trial has shown definitive benefit of survival, overall survival. So NACTRT is what we practice, what Sharad has already mentioned. So I would go with the NACTRT followed by surgery.
Yeah, so before cross trial came in, as you can see, there were multiple meta-analysis and individual randomized trials which were published. And this is a recent meta-analysis which looked at individual patient data. And they again showed that, when they looked at 2,400 plus patients data, there was improved overall survival with chemotherapy. And the cross trial, of course, showed us that the overall survival nearly doubled, and therefore, people started switching over to chemoradiation therapy. However, when you look at the comparison, neoadjuvant chemotherapy versus neoadjuvant CTRT followed by surgery, there are two small trials, not very big trials, one by Burmester and the other one was by Stahl. They showed that whereas the overall response, the R0 resection was similar, the rate of complete pathological response was much better with CTRT, and the locoregional failure rate was higher when it was only chemotherapy. So there is some evidence to tell us that only chemotherapy may be inferior to induction chemoradiation therapy. Would Dr. Basade have any different opinion?
So this patient is 71, and if you go by cross trial, giving chemotherapy radiation would be too toxic for this fellow. I don't know the overall performance status and the weight of the patient and comorbidities.
Performance was one.
But 71 years of age, and even if the cross trial, whenever we give to the patients, they have a lot of toxicities. We know that in squamous cell carcinoma, the role of neoadjuvant chemotherapy versus role of chemo-RT is there is no difference as such. So you can go either of them. So that's where I would like to look at the comorbidities and the nodal size and talk to the radiation oncologist also that if he is expecting more radiation-related toxicities, then we can go for the chemotherapy. So if there are no additional, then one can go with the chemotherapy.
Maybe Dr. Basu can enlighten us. Is he there?
No, he is.
No, okay, so Anil, yeah, please. How comfortable you would be giving pre-op radiation therapy in a patient who is 71-year-old?
So as long as the age is considered, well, we are comfortable with that as long as the patient is in good performance status. So age should not be the only criteria when you do not want to give the neoadjuvant chemoradiation therapy. However, so when we look at the PET-CT scan, so we have a celiac node, we have a gastrohepatic node, and we have a subcarinal node. So we need to rule out, so with the help of radiologist and nuclear medicine, that whether the subcarinal node is involved or not. So because what will make the life of a radiation oncologist and the surgeons would be difficult is that the long segment of the esophagus that is we are going to irradiate, as well as the anastomotic region. So as long as my surgeons are comfortable with the neoadjuvant chemoradiation therapy, I don't have any problem with giving in a 71-year-old gentleman. But if the surgeons feel that my radiation doses might compromise their anastomotic area, so because this is the gastrohepatic area and the celiac node, and the patient will be fasting, so the stomach will be in a collapse state. So the doses to the anastomotic area will be slightly higher than in the presence of a non-gastrohepatic node or a celiac node. So then I would be comfortable in neoadjuvant chemoradiation therapy followed by assessment for surgery.
So if this patient has had, say, supposing stenting, coronary disease, and now he has to be, evaluated for neoadjuvant treatment, would you be comfortable still with giving chemoradiation therapy?
Sir, the stenting...
so basically coronary artery disease patient has, which may or may not have been treated, but...
we have to be very cautious for as we have seen in the cross trial, so the median overall survival for squamous cell carcinoma is approximately 8 years. So this patient are going to survive for long. So we'll have to be very cautious about the coronary artery disease, and we'll have to limit our doses up to the heart and especially to the coronary arteries. But we are comfortable with that. So the current modern radiation oncology technique can deliver as low as dose possible to the heart as well as to the coronary arteries.
So can you just briefly, forget this case, but briefly can you tell us, the aspects of radiation therapy? What would be the proximal limit of radiation therapy? What would be the distal level of radiation therapy?
Yeah, so for neoadjuvant
field of
chemotherapy,
radiation,
so what happened is that historically we have changed a lot. So because previously we used to give 5 centimeter margin proximally and the caudally, but nowadays the people give 3 centimeter margin, so that because a lot of times you will see the recurrence in the gross disease area and not at the margins. So the 3 centimeter margin proximal and in the distal direction with a dose of 41.4 gray in 23 fashion as per the cross protocol, so once daily will be good enough. The only area where we or my surgeons will not be comfortable with neoadjuvant chemoradiation therapy is the Sievert 2 or Sievert 3, especially in the adenocarcinoma, and especially when the patient is young and a good performance status, especially when the FLOT trial results are available.
So that we will discuss adenocarcinoma. Here right now we're discussing only squamous CA. So patient with cardiac comorbidity, you would be little cautious as far as radiation is concerned.
Yes, we would be cautious because we have to be cautious, otherwise I think that is for the every modality for chemotherapy, surgery and radiation.
I just wanted to make a point here. People are talking a lot about NACTRTA followed by surgery, whether the morbidity will increase, whether the additional radiation, as you just mentioned, where there will be anastomotic problems. Our experience is that NACTRT, the radiation, in fact, after NACTRT you do surgery after 4 to 6 weeks or maybe 8 weeks down the line. There is absolutely no problem with radiation, NART. In fact, it helps the surgery because we have done we have a publication already which shows that it helps the surgery. If you do NACTRT, what my colleagues are talking about, whether radiation will complicate or increase the morbidity of the surgery, that is not so. Even Sharad will vouch for that the NACTRT actually helps the surgery in a period of 4 to 6 weeks. If you operate the esophagus, there's a very nice peri-esophageal edema created by the radiation. Microvasculature gets completely blocked and the surgery actually becomes easier, and there's no evidence which shows that NACTRT increases the morbidity. In fact, when we actually operate after NACTRT, the surgery becomes easier and the entire mediastinal dissection, everything becomes easier after NACTRT rather than going up for upfront surgery. So there's no
what
issue
you said is correct, but if you have a scenario where the disease is, say, at the level of carina or little above, the proximal margin of radiation therapy will be, right up to the clavicle. That is the situation when the anastomosis is going to be in a esophagus which is radiated. Are you worried then?
Not at all. Because
Okay.
you're pulling up the stomach, and Indian stomachs are large. They can
No,
reach
stomach
up
is
there
not a
very-
problem. I'm saying the anastomosis because the
No.
esophagus is radiated.
Sir, basically, it used, earlier we used to have these problems because even the surgical skills and surgical techniques were probably not that good. But nowadays, with better surgical skills, we don't rely on, the radiation therapy to be affecting our anastomosis.
Yes.
Because we just keep them, our sutures have to maintain the thing with good vascularity of the tissues.
So one of the reason why we don't have, anastomotic leakage is higher with when you do anastomosis in the radiated patient is because the dose is 41.4. But
Yes.
if somebody has had definitive chemoradiation and you have to do anastomosis, the esophagus is like a leather and you're always worried and the anastomotic leak rates are pretty high. But I would agree that when it is pre-op CTRT with 41.4 radiation, we don't have too many problems even
Sir-
with anastomotic.
Sir, we would be more worried if the radiation is given on the stomach side. I would not fear so much on the esophagus side.
So, this I have been hearing again and again, but stomach is so robust, there is so much of blood supply. Why should one be worried so much about stomach rather than, esophagus?
Sir, we are anastomosing at the tip. I mean, the tip of the stomach is not definitely as good, does not have so much of a good blood supply all the time.
Okay, yeah.
Permission, can I just ask one question? I'm Dr. Panda, I'm from Delhi. So, the question is the mid-level squamous cell esophagus to make their anastomosis somewhere in the neck. But if it is a G junction or sort of a squamous cell cancer, then the anastomosis is somewhere in the mediastinum. Now
I
there are
think
two-
we'll come to that later. What is the extent of resection? That
Yeah, yeah.
we'll
No,
cover
so
later
the-
on.
I'm talking about squamous cell cancer.
Yeah, yeah, I'm
Most of our
talking about-
surgeons are in lower third are a little worried about giving radiation because they think if there is a mediastinitis even in one patient, it almost certain.
We'll discuss
so
that, yeah.
particular location of cancer, whether it changes, whether
We'll discuss that. Yeah, we'll proceed with the discussion. Now, these are two other options, or these are just no longer they exist for a patient with loco-regionally advanced cancer. Surgery followed by adjuvant therapy, which could be either chemo or chemoradiation therapy, or definitive chemoradiation therapy, and then salvage esophagectomy. Maybe, surgeons, I think I'll have to ask surgeons only. Yeah, Sharad, maybe you can take this question. Surgery followed by adjuvant therapy, any takers for that?
Yes, depends. Sometimes the patients are not very willing. And then you see, I work in a very kind of remote setup with a lot of illiterate patients. Then you feel that the patient is not able to comprehend what you want to tell him. And you feel that he is not able to, he may not follow up or something. Then you sometimes go ahead with surgery. It is out of the, the
So
scientific
you
part.
can individualize the treatment depending on the
Yeah, basically
patient's
that it is.
preference and,
And
how we can...
not depending on the staging, I mean.
Okay. What about definitive chemoradiation therapy, Anil?
Yes, sir. So there are no definitive.
For tumor which is in the middle third, I'm not talking about upper third. Upper third, even the surgeons will, refer to radiation oncologists. But for something which is clearly operable, but, definitive chemoradiation.
As far as the current literature is concerned, we have the cross trial, so which says the NACTRT followed by surgery is the standard of care. However, there are ongoing randomized control trials which are looking at to avoid the surgery upfront and do the surgery as the salvage treatment option. For example, NEEDS trial. So NEEDS trial is a UK-based phase 3 multi-center randomized control trial which is looking at this particular question, that the NACTRT followed by surgery versus definitive CTRT followed by salvage surgery.
So STAL has already published data some time back which showed that, if you have the policy of salvage esophagectomy, the two arms had more or less similar survival. So it is one of the options, especially if the patient is not willing for surgery,
yes.
then you should not feel that you are giving inferior treatment.
Yes.
Okay, so this patient underwent chemoradiation as per the cross protocol. Post treatment, after about a month, when he was evaluated, there was complete relief, almost complete relief from dysphagia. And the PET scan showed that the disease in the esophagus and the GE junction had reduced both in size as well as the SUV values. The nodes also had, become smaller with lesser SUV value. So naturally, this patient went in for surgery. Now again to Suraj, what would be the extent of surgery, whether it would be McEwen's or you would prefer to do Ivor Lewis? This is in the lower esophagus.
Yes, open thoracotomy is almost like out of question. So
No, I'm talking about McEwen versus Ivor Lewis, not the approach. So, neck anastomosis versus...
So squamous cell carcinoma, lower third esophagus?
yeah.
Yeah. So it's going to be McEwen, of course. It will be a total esophagectomy with a complete mediastinal lymph node dissection. Conventional versus minimally invasive is...
Yeah, Sharad, you would have any
I would also would go with McEwen, sir.
Okay, so generally when you have intrathoracic disease, even if it is in the lower third, we know that the incidence of occult metastasis in the superior mediastinum is to the tune of 20-25%. So it is always better to do neck anastomosis where you have the capability of doing complete mediastinal lymph node dissection, and if you wish, bilateral lower cervical lymph node dissection. So, approach. Suraj, you have experience with minimal invasive surgery. So, is there any role for doing conventional surgery, or all patients should go for minimal invasive?
So all patients go for a minimally invasive. There's no point in opening the chest for this kind of a patient.
Right.
So as of today, all patients go for minimally invasive, either VATS, thoracoscopic or robotic.
And what will be your preference, VATS versus robotic? If both the things are available, you have the facility, that's why I'm asking you.
So VATS actually, I think VATS is actually a misnomer.
Sorry?
Video assist. I think VATS is a misnomer.
Okay.
Video assisted thoracoscopic surgery. We don't do a mini thoracotomy. It's a thoracoscopic esophagectomy.
Thoracoscopic, I'm talking about minimal invasive
Yeah.
thoracoscopic
So
surgery.
thoracoscopic is what I do routinely, and nowadays I do robotic.
So
I
that's
prefer-
what I'm saying. Any difference between robotic assisted minimal invasive surgery versus minimal invasive, the conventional VATS
So
surgery?
if you have the facility of a robotic surgery, that is better. That is better than thoracoscopic, because of course the robo has much more advantages with the flexibility and all this.
So if you look at the literature, there are 3 randomized trials and a lot of comparative trials which have shown that minimal invasive surgery scores much, it is much better compared to open surgery. So that is not a debate now. Whenever there is facility available, skill is there, minimal invasive surgery would be the way to go for resection of esophageal cancer. There is one RCT which has compared, again, robotic assisted minimal invasive surgery versus conventional surgery. Again, they also showed the same thing. But we don't have any comparison between robotic assisted versus minimal invasive VATS surgery. So, I think we really don't know whether robotic surgery would score over minimal invasive surgery. If you look at the outcomes, it is unlikely because both are minimal invasive surgery. I guess robotic surgery makes life a little easier for surgeon.
Absolutely.
But the
That's the
outcome
point I
for
wanted to
patient may
make.
not change.
You won't get a right tibiofibular cartilage degeneration.
Right.
You're sitting and life is easier for robotic rather than thoracoscopic.
Right. And maybe the learning curve is slightly less when you compare with VATS video-assisted thoracoscopic surgery. So this patient underwent McEwen's esophagectomy, and as you can see in the specimen, there is small residual ulcer, and the final pathology shows that there was residual viable disease, nodes were negative, so it was YPT1N0, and the PDL1 TPS score was 80%. Now, is there any role for adjuvant treatment after something like this?
No data yet.
Residual disease post-esophagectomy. Dr. Basade, you think anything? Because, patients who have residual disease, very likely to recur in future. Can you do something to reduce that?
If you look at the literature, there is no data supporting an adjuvant if you are given new adjuvant therapy. But we know that these patients will recur back. So people are trying to look, because these patients will not tolerate chemotherapy afterwards. So non-chemotherapy options like immunotherapy, there are new trials which are going on.
So I thought this was the trial which showed that in patients who had residual disease, when they were given adjuvant chemotherapy along with nivolumab, the progression-free survival was almost, disease-free survival was almost double for patients who received adjuvant chemo plus immunotherapy. But the question that I want to ask is, the trial did not compare third, I mean, there was no third arm where there was nothing was given. So maybe if patients were given chemotherapy alone, they would do better than, patients who had only chemo, radiation and surgery. That is something we don't know. But today, if a patient can afford, maybe patients who have residual disease after CTRT on final specimen, they would be candidate for
Immunotherapy.
yeah. Okay, now we go to second case. 56-year-old gentleman, again with dysphagia grade 2, 3 months duration. Endoscopy showed nodular growth at the lower esophagus, G junction, crossing the cardia, though the fundus and rest of the stomach was normal. Biopsy was moderately differentiated adenocarcinoma, and the PET scan showed FDG with concentric thickening noted in the lower esophagus, G junction, cardia, with nodes in the perigastric and gastrohepatic area. So this is the endoscopy picture, obviously locally advanced, and the PET scan showed us that there were lymph nodes also. So how would you proceed in patient with this kind of disease, Suraj?
So we'll obviously go with the neoadjuvant chemotherapy.
Neoadjuvant chemotherapy.
Yes.
You think there is any role for chemo radiation therapy? This is diseases mainly in the lower esophagus and cardia.
No, not in this situation. It's a G junction tumor. Looks like severe type 2 or 3.
No, not type 3, definitely. Type
2.
1 or type 2, bordering type 2.
But I don't think radiation will have a role to play because, if you're...
No, not radiation alone, chemo radiation, because the cross trial had both components, squamous as well as adeno, and in fact, adeno were almost 60%,
But
because...
you mentioned there's a node in the celiac or left gastric region. If there's a node lower down, and if you have to cover the entire area with the radiation, then the better option would be to give only a preoperative chemo and NACT, and then followed
Yeah,
by
Anil, what would you be kind of reluctant for something like this? The nodes were not, very
No,
bad.
I want to understand the rationale behind the neoadjuvant chemotherapy, especially in this particular case, as compared to the previous case. Because if you see the cross trial, as Dr. Mistry has already mentioned, 70% of the patient in the cross trial were of the adenocarcinoma, and approximately 70% were of the lower third disease, and G junction 20% or so. So I want to understand the rationale from the surgeon. Why don't you want to give neoadjuvant chemoradiation therapy in this particular patient as compared to previous?
I'll tell you what we follow.
Yes.
I usually discuss out with my radiation oncologist.
Sorry?
And if he is comfortable, we discuss it out with the radiation oncologist.
Okay.
If he can comfortably radiate without affecting the local neighboring organs, then we plan to go with chemoradiation therapy.
Right.
If not,
So
then...
I just want to, bring it out that there is an option of chemoradiation therapy, cross protocol included adenocarcinoma.
Yes.
So I don't think you should rule it out completely.
Yeah, so if you ask me what is the standard of care for the neoadjuvant chemoradiation therapy followed by surgery, especially in this particular patient also, but we have data available from the neoadjuvant chemotherapy also, so that should be also
We'll
be an
discuss
option.
that, yeah.
Yeah.
So if it comes to neoadjuvant chemotherapy, would be only neoadjuvant chemotherapy or it will be perioperative chemotherapy?
So it will
Dr.
be-
Basade, what would you advise?
You have two options. One can go for the MAGIC, which is 4 cycles before ECX or EOX, whatever you want to give, or you can go by FLOT. So it will be again addition of docetaxel to the oxaliplatin and 5-FU. So that is 4 cycles before surgery and 4 cycles afterwards.
So doing surgery first followed by something like McDonald doesn't make sense. It has gone out of...
McDonald probably now, no, we don't use it because in adjuvant it used only 5-FU and leucovorin, so single agent 5-FU.
Yeah, so, talking about perioperative chemotherapy, FLOT versus MAGIC treatment, MAGIC perioperative chemotherapy has been compared, and we know that FLOT is better. So most of today the standard of care is FLOT. MAGIC is something which we don't do. But now there are 2 trials which are, testing preoperative CTRT, that is cross protocol versus the FLOT. And once we have the result, we'll know which one is better or both are more or less equal.
Sir, I think the neoadjuvant preliminary results are out. And they have said that the neoadjuvant chemotherapy, that the FLOT regimen, so versus the cross regimen, FLOT regimen is non-inferior. So you can have the FLOT regimen in neoadjuvant setting as per the adenocarcinoma.
Okay, I was not aware of that. Now, Suraj, what is the role of staging laparoscopy in patients who are planned for surgery after induction therapy, but before doing induction treatment?
So, if you talk about CBER 3,
Yeah, 2 or 3, yes. Patient has clearly operable on PET CT scan, on endoscopy. So we are planning pre-operative, say, FLOT. But before we start FLOT, would you like to do staging laparoscopy? Because a lot of people recommend this.
no, if it's like a type of gastric, going towards more of a gastric type of cancer, then there'll be a role. Otherwise, CBER 1 or 2.
No, we're not talking of ZVERT 1. I
We're
mean,
talking
2
about
or
squamous?
3 I'm talking.
Are we talking about squamous or adenos?
No, adenos, ZVERT.
No. So CBER 1 or and 2, I don't think there's any role, but CBER 3, maybe we can do a staging
Yeah.
laparoscopy.
So this is something which I always find, patients are advised to undergo staging laparoscopy even before the treatment. And I always keep wondering, it is operable, and why do you want to do staging pre-treatment, pre-induction treatment? But this is something which is recommended, and therefore I thought I should bring it out. So this patient received 4 courses of neoadjuvant FLOT therapy. He tolerated well. PET CT scan showed that there was significant reduction in the primary tumor and the nodes. And then he, of course, underwent surgery. So in this type of tumor, adenocarcinoma type 2 maybe or type 3, what would be the extent of resection?
So I would go for an Ivor Lewis straight away.
Right.
Because,
So anything which is ZVERT 2, one can go for Ivor Lewis because there's going to be adequate esophagus,
yes.
normal esophagus available.
so the Garlock gastroesopectomy has got limitations because
Yeah.
Ivor Lewis would go up to almost like a 2-field lymph node dissection, clearing the infracarinal, right and left bronchial, and do the lower mediastinal dissection. So I would go with Ivor Lewis for this.
So,
patient.
but for something like ZVERT 3, which is more like gastric cancer, maybe where the esophagus is not significantly involved, you think RA would be, that is what we say in, all who are trained in Tata, Garlock's approach, would it be adequate?
No, I would still go with Ivor Lewis.
I will
because
lose.
I
But
would-
the
I would
concern
need to
is
do a
that
lower
if the
mediastinal-
stomach is significantly involved, whether you will be able to reach the, the stomach tube will be able to, adequate length will be available for
Stomach would
anastomosis in the neck.
It will always reach up to the infrazygous area. The
Okay.
stomach will always reach there.
So your preference would be always Ivor Lewis?
Ivor Lewis for me,
Okay.
or Ivor Lewis.
So this patient underwent Ivor Lewis esophagectomy, and then of course the final specimen was YPT2N2. Obviously this patient, as planned, received 4 courses of FLOT post-operatively also. But if you had a scenario, upfront PET CT scan showed something like this, huge nodal masses, but no distant metastasis. How would you treat Dr. Basade? I mean, obviously surgeons would want to do because the nodes are not in the preview of, surgical resection, even when you do after chemotherapy. So what kind of approach would there be? Chemotherapy alone, chemotherapy plus immunotherapy, or just straightforward chemoradiation therapy?
For the same adenocarcinoma.
Sorry, adenocarcinoma, yes.
So I will go again same with chemotherapy alone at present. Because if it's a bulky, then the radiation oncologist will have some an issue. Newer data are with the immunotherapy people are combining, but at present we go by the FLOT.
But today data is available that combining it with immunotherapy, either nivolumab or Pembro have shown improvement in the progression-free survival. So that is an option that we should keep in mind in patients who have locoregional disease, but extensive where surgery or radiation is not going to be adequate. Okay, last case now, and very quickly, because the same 64-year-old gentleman, grade 2 dysphagia, grossly overweight. Endoscopy showed locally advanced cancer in the middle and lower esophagus from 28 to 33 centimeter. Patient had also a fairly large hiatus hernia. That was the PET CT scan, no nodal disease, just disease localized to the esophagus, but bulky. He underwent induction chemoradiation therapy cross protocol. At the end of 4 to 6 weeks, I can't exactly remember, patient had complete relief from the symptoms. PET scan showed complete metabolic response, and endoscopy showed very superficial ulcer. It was thought to be radiation-induced, biopsy was negative. Now, how do you proceed? Is there any option of just observing this patient, or he has to be taken up for surgery?
So,
Yeah, would you be comfortable, Suraj? He has received pre-op, cross protocol, 41.4.
Yeah, so as per the cross protocol or in the Indian scenario, we should go ahead with surgery because we have to stage the initial disease and we are not very sure of whether it's a complete PCR, pathological complete response. So in the Indian scenario, I would still go ahead with with surgery. But of course, there are no recent trials or studies, ongoing trials, which saying that we can observe. But observe meaning regular endoscopy, regular bite-on-bite biopsies, regular PET CTs, whether it is feasible in the Indian scenario, it's very difficult to say. So in our condition, I would straight away go as per the initial staging, and I'll go ahead with the surgery if the patient is willing, if the patient is affording and willing to, have a very close observation. And then the second option is to...
So Sharad, have you done that observation, patient under surveillance, close surveillance, post-complete
surveillance.
metabolic
Sir,
response?
Sir, presently there is no clear data available for observation. So in my present setup, I am going to most of the time operate.
No, I'm just asking personal
In practically-
experience. Yeah, in
Practically,
practice.
sir, it becomes costly for patients to follow up in my region. So they would
Anil,
prefer
I
to-
want to ask you, what is the difference between, say, 41.4 versus, say, 54, which you would give in definitive chemoradiation therapy? Because that would make life easier. I would be more comfortable keeping the patient under observation, surveillance, if there is complete metabolic response. And on endoscopy, biopsy, you find there's no disease.
Yeah, so there's a difference between 40 gray and 50 gray because the 40 gray will not give you a radical doses. So in North America, all of the centers, the majority of the centers give a dose of 50.4 gray even in neoadjuvant setting.
That's what
so
I was
50.4 gray in
commenting,
28 fraction and then followed up with the surgery. For this particular patient, we had some patient who had not, who did not undergo surgery. It's for the same reason that the patient were feeling all right, they were having no dysphagia, and we had some patient. But obviously, as doctors have already mentioned,
No, so that
there is a
as
toll.
per plan, you would want to go through esophagectomy, but I am
Yes.
talking about instances like, like you said, not many, but fair number of patients after chemoradiation, the response is so good, even if it is not complete, they are reluctant for surgery because they don't have dysphagia anymore, and then they come back with disease again. But if it was 54, then you would not feel guilty because you can, of course, do salvage
so we'll have
surgery.
to counsel the patient first that the patient will be planned with the neoadjuvant chemoradiation therapy and followed by surgery. The treatment will not be neoadjuvant chemoradiation alone. So neoadjuvant chemoradiation therapy followed by surgery will be the standard of care, will be the treatment. So we'll have to inculcate that treatment into the patient's mind so that they don't feel like
so
that
this
neoadjuvant
patient, he was not willing for surgery, but I was really reluctant because he was grossly obese. He had hiatal hernia, and that patient was, somebody who could be followed up very closely. So we followed it every 6 weeks. We were doing endoscopy at 3 monthly interval. We were doing PET CT scan, and today at the end of 2.5 years, he's still free of disease. So it is an option which should be explored, and this is what has been, examined even in literature. If you see the pre-sano surgery as needed trial found that, patients who had complete response at the end of 6 weeks and 12 weeks, they were, followed up for salvage only. And what they came up with conclusion was that this protocol was poor as far as sensitivity or detection of absence of disease was concerned. Presence of disease was, of course, easily detected, but absence was something which was difficult to detect. So they have now started a SANO trial. It is a non-inferiority trial to see whether you can have the surveillance program. And then there are 2 more trials which are actually looking at this. And the Asian trial is looking only at squamous CA, because the squamous CAs are, the ones where the complete response rates are almost to the tune of 60+%. So the topic that we have, since we have only 30, 40 seconds, anything that the audience would like to bring up? Yeah, you wanted something, yeah. if we have not answered your
No,
question.
the 649 trial you mentioned regarding neoadjuvant with nivolumab.
Not neoadjuvant, adjuvant I'm talking.
No, sir. The neoadjuvant chemo with nivolumab, you made checkmate 649 as a versus chemotherapy versus chemotherapy plus immunotherapy.
No, that was post-op for residual disease, I said. Post-cross, if there was residual disease, we have
No, I
option
guess he's
of
talking about the
not giving
metastatic.
anything.
I think, sir, that I have understood. After that also you have, when you question about the role of neoadjuvant chemo plus immunotherapy
No,
versus...
that was for, thank you very much, once again.
Done. Out.